Right. The alternative way of using condition-specific data is to generate QALYs directly. So describe the condition-specific health states and then use time trade-off or standard gamble or any other elicitation method in order to derive the weights that allow you to calculate the QALY. I'll give you one example of this. This sticking with the cancer. Still using the QLQ-C30. So with the QLQ-C30, remember, you've got all this data here. You've got 30 items, really quite rich data. And so the question is, how can we get from this quite rich data, how can we weight different items in order to get a preference-based measure? And that's what has happened with something called the EORTC8D. They developed an 8-dimensional measure. So what they did first of all was take the initial 30 items, which is too much information, too many potential combinations, etc., and reduce that down to 10 items. Essentially what they're saying is, of these 30 questions in the QLQ-C30, 10 of them contain more information than the rest. Some items might in a way be duplicating, so you could get rid of them because they're not adding. Or some items may not be adding just very much knowledge or information. And so that gets them down from 30 items to 10. They then allocated 6 of the items to particular dimensions, and another 2 dimensions were based on a combination of 2 items. So this item reduction took place, and they end up with a measure that's got 8 attributes with 4 or 5 levels for each attribute. Compare that with the Q5D5L, 5 attributes, 5 levels. But if you have 8 attributes with 4 or 5 levels, that gives you 82,000 potential health states. Now, it's probably still too many, but anyway, that's where they stopped. So they said, right, we've reduced the number of items, so our descriptive system, our EORTC8D, is going to allow us to identify 82,000 different health states. They then have to value these health states, and the authors, Rowan et al., University of Sheffield in England, then selected 85 of these thousands of health states to value. And they asked a sample of respondents to time trade-off questions, and they asked each respondent to value 8 health states. So 8 of these EORTC8D descriptions. And then they do a regression analysis of the responses, trying to explain the numbers that people gave in terms of what level each dimension was at. Again, an additive model. And here's a snapshot of the results. So instead of health states like 21112, we've now got a telephone number of a health state. And so this is an example for the health state 212323342. No answer. And it's a description of a health state. For example, you have a little trouble taking a long walk. You're not limited in pursuing your hobbies or other leisure activities. Pain interferes a little with daily activities. You feel quite depressed, and so on. And so taking the coefficients from their model, these things here, you can estimate a score for this health state. And the score is 1 minus these different bits. And we get 0.708. And so what they've done is they've produced a condition-specific QALY, a cancer QALY. Because they're using a descriptive system, which is designed to be specific for cancer, It's preference-based. They've established how important mobility is compared to pain, compared to depression, compared to tiredness, nausea, etc. So it's going to be almost by definition more sensitive than EQ5D.
0.708 is the QALY.
It's the quality adjustment. This is the health state score. So time spent, a year in this health state will be scored at 0.708. And so a year in this health state would generate 0.708 of a QALY as compared to being in full health for a year. Personally, when I look at this, I don't think 0.708 is too bad. You know, I might have scored it more lower, but anyway. Okay, so that's, I will close shortly. So a few final comments on generic versus condition-specific health state values. As I've said at the outset, I want to emphasize again, there is a preference for using generic QALYs because of this interest in comparability. If we take the cancer QALY, is that QALY more or less than a QALY that we'd get if we used EQ5D? We don't know. And so that's the big worry, that if you embrace condition-specific QALYs, you lose potentially comparability. Also, it's not very important, but research costs as well. With the EQ5D or any other generic preference-based measure, we've got the numbers. We can use them again and again. If we're going to develop condition-specific QALYs, we're doing this research fresh to some extent each time. Now that's great for academics, but it's not so good for anybody else. Condition-specific data, however, is richer. Typically, the data will be available at many more points in time. For example, QLQ-C30, you may have routinely collected every time the patient came in contact with the health care provider. EQ5D, you've had to bargain with the trialists to collect it at baseline and maybe once at 1 year or something. But of course, the big reason for condition-specific data being possibly better is it addresses directly the concerns of the patient. Now, EQ5D has been criticised quite widely for not explicitly including fatigue. And fatigue or tiredness is particularly important in the cancer area. Of course, EQ5D is still picking it up, because if you're really tired, that's going to have an impact on usual activities, maybe on mobility. It might have an impact on how anxious you are, etc. But it's not being picked up directly. And so I wouldn't, while I'm sort of embracing generic preference-based measures, I wouldn't try and argue that across the board they're better. I just think on balance it might be better working with them rather than moving to condition-specific. A few reasons here why condition-specific may not be better. You might design a measure that picks up lots of change, but the change is not actually very important. In a way, a merit of the EQ5D or some other generic measures is it needs something quite big to move it, to change it. And so you can be pretty sure if you're picking it up with EQ5D that it's a bit more real. Whereas some of the change you might pick up with a very sensitive measure may not be too important. The other problem with condition-specific measures is they might pick up important changes, but they may miss some important changes because they don't always capture the general health of the patient. They're so focused on condition-specific items, they can miss perhaps the impact of some comorbidities on general health. So they may not be broad enough. I think the final point I'd make here is it's not the best argument, but decision makers are used to using generic measures. They think they know how to interpret them. They're less sure about how to interpret condition-specific. And there's a summary. At least in the UK, there's a clear hierarchy. I'm not saying it should be the same everywhere else, but patient-reported EQ5D valued using public preferences. This is something I haven't gone into actually, public versus patient preferences, but public preferences. Then if you haven't got those data, EQ5D from the literature, if you haven't got that, map from other measures to EQ5D. And the least attractive is to look at alternatives to 5D, but then you need some evidence as to why the alternatives are better. And that's a good point to stop. One, because it is time for lunch, but two, we're going to look at alternatives in the afternoon at 1 o'clock. Two alternatives, main alternatives, using money to value health outcomes, and the second one, using measures of life satisfaction or well-being, or alternately, possibly considering using happiness measures. Okay, so we stop there. Quick question?
Yesterday, you introduced which is an example of MDS, and I believe it's a pediatric disease, so it would be difficult to assess the value of each cell space. So, could you show some idea for such difficult situation?
So,
children.
in children, yes, right. There are various measures in children, but there's one generic preference-based measure. Sorry for those people who, I'll find it somehow. And that's it, yeah. This thing, CHU9D, is the Child Health Utility Index, 9 dimensions. And it's the first preference-based generic measure designed for children. It's been designed for children aged 8 years and upwards, although I've been doing some research with it where by changing the technology of collecting data, using animation on a tablet, we've collected data from as young as 4 years old. Now, the dimensions of this and the levels have been carefully chosen to be more relevant to children. Everything else is an adult measure, and what's relevant for adult may not be relevant at all for children, or certainly less relevant. We don't have a huge amount of data on it yet, and there's a very interesting problem for economic evaluation, and that is if the condition has consequences over time. Initially the child is a child, but in due course they're going to be adolescent and then young adult and so on. How do we get a consistent QALY estimate over time? Because if we start by measuring the CHU9D, it's very relevant to them, but then as they become adult or nearer adulthood, do we change to a different measure? So there's a lot of problems we haven't faced yet. But I think with respect to a specific question, I think things like EQ5D, they have been used with children, but they're not designed for children. CHU9D is probably the best bet. There are a lot of other measures, things like PEDS QAL, PEDS QL, but it's not a preference-based measure. It's back to a measure where you score different items and you treat all items equally and add them up.
Ultimately, can we use overall survival rather than poorly adjusted survival in MD situation? No.
Certainly we can, but the counter-argument is there's more important. We don't just care about life or death or survival. We're interested in the nature of the survival. So there are a lot of studies that do calculate, for example, as a measure of cost effectiveness, the cost of an additional life year. And so it's just a year of life. It's saying nothing about how that year of life is lived, but it's a cost per additional year of life. And that's certainly a possibility. But for many conditions, people feel, I think correctly, that you've got to consider something about the nature of the life as well, and not just whether somebody's alive or dead. But with respect to some pediatric conditions, maybe that's the best we can do, just look at life years gained and focus on that. Yeah. Okay, thank you for your question. Okay, right, thanks very much. We resume in an hour, yes, 1 o'clock. Okay, thanks.